topic today is, it's called Step Perio. It's one of the things that we do to try to ensure that we keep as many patients as possible, especially these perio patients. The problem is patients don't know they have the problem, and you say that you can't get a cleaning here, essentially, unless you do scaling, and the patient decides to do it or doesn't decide to do it. And the ones that don't decide to do it, you lose them because they're not on the schedule and you're not allowing them to come back. And the ones that do it, far too often we're finding don't stick with the practice anyways.
Correct.
Long term. So what I encourage everybody to do after you listen to this, to identify if you've got this problem or not, is to go back and look about 13 to 14 months ago at all the new patients you've seen, okay? Pull out the ones that were diagnosed perio and see if they're with the practice. If your numbers are at 50% or below, you've got a problem.
For sure.
And we like to shoot for 60% or higher to stick with the practice after that length of period. If you're below that, you'll find that most of you will be shocked to see it'll be around 30, in the 30s, sometimes even in the 20%. I haven't done this study where it was 0.
Yeah, really.
Yeah, it was a 0. And we're talking quite a few patients, not just, 5 patients. We dug up 30 patients and none of them were with the practice. Not a single one.
Pretty discouraging.
Yeah.
Pretty expensive too.
So first identifying the problem and then fixing it. And we'll talk about different various ways to fix it. But the key to growing a practice is to get a lot of new patients and then keep them all. It's that simple. If you do those things, eventually you'll get all the dentistry. So the long-term strategy is to work on retention of new patients, retention of your hygiene patients, your recall. So this is about retention of a specific type of new patient. And the more that you diagnose perio, the more you're in rural areas, the more you're going to run into this conundrum. How do I deal with this? How do I deal with insurance? And so that's why we got Dr. Peterson here, who is a periodontist and has navigated a lot of offices through this problem. And let's take it from there. You identified kind of this problem and then did a study on a few practices to see how it played out. Why don't you just...
Yes, correct. I want to stress again, this is not for your high commitment patients, new patients.
What's a high commitment patient?
A high commitment patient is someone that knows your office, has a connection with it. A really strong connection would be the spouse of an existing patient. A good connection would be a next door neighbor or a good friend of a current patient. Those people have a connection with you. They may not know you personally, but they know you through
this problem. Yeah, it really gets magnified when you really start doing external marketing.
Yes.
Because you bring in patients that don't have the commitment to your practice and then also probably haven't been to a dentist in a while.
Often the case.
Yeah.
The low commitment patient, the marketing patient that you hear us talk about so often, and you've all heard Greg talk about the perfect storm. That's who this is designed for. Those are the people that don't know you. They're not inclined even to trust you. They think that it's going to be a bait and switch, but they're there for the deal. The new patient special, $49, whatever it might be.
Right.
Exam, X-ray, cleaning. They just think there's going to be a catch. And there can't be a catch. If there's a catch, you lose them.
You lose them, yeah.
Yeah,
right.
And the catch so many offices put in there, and look at some of the ads you see in your area. Underneath that $49 special, there'll be fine print that says,
healthy
mouth cleaning only.
Right.
And there you go. So what anybody with periodontal problems, you're sending them out the door. And if you make that the condition, they think you're trying to pull one on them. So our question or our dilemma was, how do we avoid that? How do we get around that? So the actual case that really got us to where we are today was one with a client in Florida. And this was an office that had one part-time associate, a full-time owner doctor who worked more than half-time, but not a lot more than that, and did a lot of marketing. to the tune of 100 to 120 new patients per month. So their marketing was effective. They got a lot of people in the door, but the practice was actually shrinking, especially the hygiene. And we all know people get their dentistry done where they get their teeth cleaned. So it's important to keep those people.
Right.
So we wanted to figure out what is going on here. You've got 100 and some new patients a month,
Right.
and the
they're all
dentists aren't,
leaving.
and the dentists aren't busy.
Yeah.
So what?
And
is going
hygiene
on?
was shrinking.
Hygiene was shrinking too.
Yeah, right.
Over the previous several years, they'd gone from over 2 full-time hygienists. In fact, they had 2 plus some extra, down to 1 full-time and 1 that did another day and a half.
It takes approximately somewhere in the neighborhood of 500 patients to fully maximize a hygienist. And this means a lot of 6-month recall, very little 3-month recall. So if there is a lot of 3-month recall, maybe it's 400 or something like that. But they're flowing in the patient load in a year of, they should be adding 3 full-time hygienists if they were retaining every
Well, a
single one.
20-year practice, even with an area that can have quite a bit of turnover, because people come and go from certain parts of the country. Here is one of those. But you should be growing your hygiene, not shrinking.
Right.
There's something seriously wrong. So we put together a study to try to see where these people were going. Why weren't they staying? And we essentially broke it down into 3 groups. The first group, people that 1 year later were still in the practice. Second group, people that had their examination, did some treatment, but never finished it and were not still in the practice.
All 1 year later.
Yeah, all 1 year later. And then the third group were people that we never saw, or they never saw beyond just the examination. So those were the groups. We then broke it down further to see what things those groups had in common. And what we found in the groups that they lost was perio, because we were looking, were they overwhelmed from the size of the treatment plan? Was there something else? Those things were factors, but they were minor. The big one was perio. Almost, in fact, virtually all of these people had been told they needed replaning, scaling, soft tissue management, something.
80, 90%.
Oh, yes. And that also relates to the number that they lost. When we did the calculation, at 1 year, 89% of the new patients were not still in the practice. That's a huge number. It's a huge number.
When you guys do this study that I talked about, if you do it on all your new patients, I've seen ranges in most normal practices only retaining between 30 and 50%, which is really for the most part, it's bad. And for the most part, you're actually, at those numbers, your hygiene starts to slip. You're not actually able to keep it filled. And you need to be at 60% or higher to get upward trajectory to where hygiene starts to fill, and you need to add days, that kind of thing. 80, 90% gone is not good.
No, and think of just the finances of it. If it costs you $250 to get the phone to ring,
right,
and you bring them in and you take them through the process and you're keeping 1 out of 10, your cost on a new patient is several $1,000s.
Yeah.
So it really becomes this financial strain on the office too, and it's a bad trajectory. So we found they were losing most of their patients, and we then found that perio was one of the factors. So we looked at how they were doing perio, how they were presenting it, and as we said, everybody, almost without exception, was told they needed some form of soft tissue management, periodontal treatment. Typically, $1,000 or so was the cost. So most of the people were lost right at that point. They went through the exam, they were told they needed that periodontal treatment, they never came back.
Right.
The ones that did some treatment of some kind and they lost, the bulk of them went through the scaling, root planing, soft tissue management, and were angry after that and never came back. So perio was the common factor in all this. So I looked at what was really happening, and the people that went through the soft tissue management, typically had a 90-minute appointment with the hygienist for $1,000. And sometimes it wasn't even that long. They walked out of there unhappy. You know, oh gosh, I had a $49 regular cleaning and now an extra half hour was put on and it cost me $1,000.
Yeah, how is this?
How would you feel?
Right.
How would you feel? So they lost those patients. The ones that never came back or that didn't go through anything, also they just heard the numbers and they were gone. Two things to talk about here before we get into the actual how do you save these. The hygienist, the main hygienist, the one that was controlling the entire practice and how new patients flowed through, because they came through hygiene with the exception of emergencies. She did all the evaluations, she determined the periodontal treatment plan, and she did it herself, and she was on commission. The other hygienist did mostly recalls, but she could keep herself busy with the few patients that agreed, and after that, they were gone. She didn't care.
Right.
So this was working very well for her. She was making a salary that a lot of dentists would have liked to have made because of what she was doing. And the owner doctor really wasn't sure that this was the problem because she was producing real well.
It's the solution, not the problem.
Yeah.
I ran into that also, same thing.
Yeah, but you can lose sight of the dollars tripping over the nickels. And,
Yeah, right.
And that's really what was going on. So, because they weren't doing any dentistry and
Right.
the dentists were sitting around. So our question then was, how do we keep this from happening?
Yeah, how do we fix it?
What do we do? So there were several things. Obviously, when you overwhelm a new patient, as Greg says, they don't buy less, they buy nothing. So you can't overwhelm them. You've got to show them that you're on their side and what you're doing is in their best interests, and you're going to take care of it. You're going to do things that are right by them.
Mm-hmm.
So if you have, first thing I always recommend is if you have an advanced case, a type 4 that comes in, or a very atypical perio case, you're not going to see a lot of those, send them out. You know, don't make your life miserable by dealing with them. Send them to the periodontist.
These are patients with immediate problems. So
yeah, or terribly advanced problems.
Right.
It's going to be bone grafting. It's going to be a lot of different things. Unless you're really comfortable with doing that, why put yourself through it?
Right.
So that's the first thing. Now, the rest of the cases, as long as they're in your comfort zone, you want to hang on to them. So do correct evaluation first. Now, what does that mean?
Yeah,
because we're dealing with a new patient coming through hygiene, and let's say it's a 90-minute appointment.
Which that's very typical.
Yeah, which is pretty typical. Some people do it faster, some take more. 90
Right.
minutes is typically what you can do. Now, the hygienist is going to say, how can I do a full examination, take x-rays, take pictures, do full peri-evaluation, clean scale, doctor comes in, there's no way.
Right.
Well, actually there is, but you have to use some logic and some decision-making along the way. For example, if you've got a pretty involved case, the tissues are inflamed, there's a lot of gunky stuff there, there's a lot of supragingival calculus, you're not going to clean that all up in the 20 or 25 minutes you have allotted to you. So you tell the patient after you've shown them, this is a probe, this is a pocket, this is what we're looking for.
Disappeared.
Tell them what you're dealing with. These are signs of infection. These are a problem. Now, all this stuff that we see, I'm going to do as much as I can for you in the time we have allotted today, that 20 or 25 minutes.
Right.
And we're going to see how much we can get done. And that's what you do. Now, are you going to take full 6-point probing on every tooth? No, you don't have to. There's nothing that says you have to do that at the first appointment. You can do what's called a periodontal screening and reporting evaluation. And that's a process of gathering information from each segment of the mouth about pocket depth, tissue condition, amount of debris, and accumulations. And it's very simple to do. It just takes a few minutes. It's approved by the ADA. It's approved by the AAP. It gives you a good screening tool.
Okay.
Now, you're going to do full mouth probing at some point, but just not at that one, because it takes too much time.
Okay.
Then you go ahead with your 20 minutes. It may just all be with the Cavitron. You might just be doing as much debridement, removal of heavy calculus that you can get done. When you're done, you show the patient what you've accomplished, with the mirror, take some pictures if you need to, and you tell them, we've done as much as we can. We'll want to see you back to see how much improvement that we have in about 4 weeks. Now, the doctor's going to come in also, do his exam, talk about dentistry, so forth. Obviously, you've got to get the tissues healthy before you can go ahead with any
Dentistry.
complicated dentistry.
Right.
Maybe, you do emergency things, but you're not going to do crowns and bridges when you've got bleeding pockets and things like that. So when she finishes, she'll explain to the patient what she did and say, this infection is significant. There's quite a bit of breakdown and problems here. I'm going to ask the doctor to put you on an antibiotic so we can knock down this infection. Between that and the debridement that we've done today, we should see some significant improvements in about 30 days.
Okay.
The medication we recommend is doxycycline hyclate, 100 milligram tablets. 10 tablets is fine. 1 tablet a day is all it takes. This is extremely effective in killing many of the bacteria related to periodontal breakdown. So we want you to give them that. Of course, if they're allergic, that won't work, but very few people are allergic to tetracycline. The main problem, and you need to tell people about this, is photophobia. You can be more susceptible to the sun, sunburn, so forth. So we always tell people, regardless of their skin pigmentation, that they need to wear sunscreen and wear a hat when they're outside. Because it doesn't matter if you're light skin like I am, medium skin or dark skin, you can still have this issue show up. So you warn them about that, but you'll see it rarely. Then you give them some pamphlets on periodontal disease, and you reappoint them for a reevaluation. And that'll be a 30-minute appointment. And at that appointment, you will get full mouth probing and talk about anything that's necessary from there. But what happens really in that month? Well, physiologically, you're going to see a significant improvement in the tissues, and they're going to shrink. Things are going to look better. Patient's going to be looking and seeing the changes that occur. So you're going to see actual physical improvement in the problem. But what you're really seeing is you've given the patient time to own the problem, because they really didn't own it when they came in. You're giving them time and the information to own it, because you've given them some pamphlets to read. And if they've got any sense, they're going to get online and look at periodontal disease and get some more information.
Right.
What is that? And when you bring them back, they'll typically have a whole different attitude. And your success rate then, is your conversion point then is, now that they've come back, they're showing you that they're concerned.
Mm-hmm.
Now you can present things logically and the way treatment should progress from there, and the appropriate scheduling, and you should have a very high level of acceptance. When we initially started doing this, I asked some of the offices to keep track of what their success was,
Right.
and it was about 50%. Actually, it's gotten better, because it's probably around 60 to 70. And I'm talking about a couple of offices in Texas that are really good at it.
Mm-hmm.
Their retention rate is very high. In fact, they said they save most of them.
Right.
So by far, so this is good.
Now, yeah, keep in mind that the average practice loses 70% of their patients within a year anyways. That includes all new patients, 60 to 70%. So retaining 60 to 70% of these
high risk
patients with something that they didn't realize they needed, that's doing something.
It is. It's really quite good. And again, we realize that these patients are high risk, and you don't then just bomb them with everything. You still prioritize and talk to them about what needs to happen from there. But the success rate is much, much higher, and it has made a big difference for many of our offices in their patient retention.
Huge difference, yeah.
So,
okay, so a couple questions that typically pop up, so I'll play kind of devil's
Okay.
advocate here, is, okay, we did the $69 special. How do I bill insurance if they have insurance? And of course, you got to bill insurance the $69 special, but it's not a, how do you bill? It's not a pro fee. It's not.
It's not. The good news is most of the patients that come in on your new patient special don't have insurance.
Right, yeah.
The bad news is some of them are insurance. So make it easy on yourself. If you don't call it a pro fee, don't even bill that. I mean, frankly, just bill the x-ray and exam and for $69 and don't even write up the other stuff and don't even bill for it. If that makes you twitch in the middle of the night and you got to charge something, then I would call it a partial debridement, incomplete, and you have to do it by report. So
you might want to, from where this sounds, is to run a special on exam and x-ray being $69 or whatever it is, and the cleaning is free essentially.
Well, yeah, I call it exam, x-ray, cleaning, whatever. But,
right,
but bill it as you.
And bill it as exam and x-ray, discounted down to the $69 and the cleaning at no charge.
Yeah, just make it easy on yourself. Describe what you do, always on your chart, describe exactly what you did, but you don't have to put the code in there and charge it out. So you're gonna catch up for that later after with the other work that they need.
Some other common problems is how do you deal with a patient that just wants the cleaning? I just want, I hear you, and sure, I got bone loss, sure, but I just want to get a cleaning. Can I just get a cleaning?
Yeah, good question, and this is something that does come up from time to time, and the concern always especially with the hygienist, is that malpractice?
Right.
Am I not fulfilling my duties to this patient by not completing the treatment that they need? Well, it's a good argument, and frankly, some people would say, boot them out of your office.
My wife got booted out of an office
by
a friend of ours she went to, and the hygienist said that she needed scaling, and she asked, can I just get a cleaning today? You know what I mean? I don't want to spend $1,000 today. Can I just get the cleaning? And they essentially said no.
Yeah. Think about it. Is that how you would want to be treated?
No. If I go somewhere and I want just a regular cleaning, they tell me it's not going to do very much good. Tell me what I need. I'm not ready to spend $1,000 today. You know what I mean? Or $600 or whatever you want to charge for it.
Of course.
So can't you do something?
Yeah.
That's the question. Can't you do something that's helpful to that patient?
Yeah.
The answer is yes.
You absolutely can, and frankly, in my opinion, you should. Now, what do you do about covering your tail?
Yeah.
You have certain legal obligations. You have to do a thorough examination. You have to record your results. You have to discuss with the patient what you found. You have to tell them what the recommended treatment is, and you have to tell them the consequences of treatment or no treatment or treatment options. So those are the things you're obligated to do. But you can do all that.
And I'm here to tell you, it does you no good to boot a person from the practice. It is not in the patient's best interest. It's in their best interest to come back every 6 months, do probings again, and be like, Wes, it's getting worse. And then again, 6 months later, it's getting even worse than last time. That is more helpful than booting me out of the practice.
Of course. Who benefits if you lose the patient?
Right.
The patient doesn't benefit because they're not
coming back, and they're not getting recharted and not being warned it's getting worse and getting worse and getting worse. And eventually, a patient will do something about it. But to just treat them like
a bad child.
Yeah, they're not ready to spend $1,000. And quite frankly, a lot of these cases take time to really develop, years.
Yes.
So it isn't an emergency $1,000 that needs spent, in my opinion.
In most cases, yeah. And remember, patients have an option. I mean, you, as a patient, have the right to decide what you want to have done.
And when you want to have it done.
And when you want to have it done. And this really came home to me, and Wes has heard me say this.
Right.
When I had cancer, and I talked to my physicians, the oncologists, surgeons, so forth, and they went through findings, what my status was, what my options were, and what the possible outcomes would be, just like we talked about. And one of the choices was don't do anything and see what happens.
Yeah.
Well, they know it's going to happen. It's just how long. So
Right.
that wasn't my choice. And now I can say I'm cancer-free for 12 years, which is wonderful. But as I thought about that later, I said, if I had the right really
To refuse.
to refuse life-saving treatment, tell me why someone that has some gum problems doesn't have the right to say, I understand the problem. I just don't want to do that. I want to do something lesser with the understanding that it maybe will help, but it's not going to fix it.
And yeah, most of these people are not in danger of losing teeth in the next 2 years, most of them. And those cases ought to be, like you said, shipped off anyways.
Yes, correct.
So the emergency status of these patients it's just not that grave. And so by treating it like that it's, hey, you need to spend $1,000 today or else we're not going to see anymore, it does nobody any good.
Nobody benefits.
Nobody benefits.
So if you keep the patient in your office and they have put those conditions on you, you can deal with them.
Mm-hmm.
Document.
And you can track and say, hey, we're getting more bone loss. Here's another x-ray. You can see the differences. The pocketing is getting worse. Wes, you need to do something. That benefits the patient.
Yes.
Right.
And we all know the possible or the relationships that keep popping up through research between periodontal disease,
And
essentially
everything else.
chronic infection in the mouth, and a lot of other general systemic entities. So it is frankly for their health too.
Yeah, for sure.
Something in this case is better than nothing. If you can reduce the inflammatory load, you're going to help their health. So that's two-step perio, and it works.
It works very well.
We've been dealing with it over 5 years now. We have offices that are highly successful with it. It works because of the psychology.
Right. Most of you, if you're dealing with a high percentage of your practice that are referrals, patient-to-patient referrals, you're not going to typically have this kind of problem. This problem really creeps into a practice when you start ramping up marketing and somewhere in the neighborhood of 50% of your new patients come through another source than word of mouth. Is when this becomes a real nightmare problem to deal with. And you have to deal with it. You have to, if you want to grow your practice, you have to retain above 60% of this new patient flow from this type of source to the practice. And so you need to track that and make sure that you are retaining those patients.
Yes. And if you're interested we've written up the protocol for retrospective studies, the one that we put together with that first office. And a lot of our offices have used it. And I can't think of one that hasn't said, my gosh, I had no idea.
I've done this, not for perio, but just new patients in general, where we do a study when we first get a client, or I first get a client, where I look at, a year, 14 months ago, so a little over a year, who had time to get 2 cleanings in, hopefully on a new patient. And the numbers that come back are embarrassing.
Yes.
It's between 30 and 40% on the average practice. I've never had a practice that generated a healthy amount of new patient flow, 30 or above, start off at 60%. It's very shocking and revealing.
And our offices that do this will tell you 2 things. It's a challenge. You've got to get the protocol down. You've got to present it well, and
you got to get the hygienists to buy in.
The hygienists have to buy in, and sometimes they don't want to. And
you got to show the numbers, how many people we're losing.
Yeah, it's about the numbers, and if they need to talk with one of us or me, I'm happy to talk with them.
Absolutely.
So we can do that for you. But this is something that really does work.
Yeah. All right. Thanks for listening.